Welcome everyone to our webinar, Beyond the Clinical Thermometer, Heat and Health Equity. Before we begin, all of us at the Medical Society Consortium on Climate and Health respectfully acknowledge that our advocacy, education, and learning across the country takes place on the occupied and unceded lands of many Native American tribes. To acknowledge this land is to recognize its long history and our place in that history. It is to recognize these lands and waters and their significance for the people who have lived and continue to live in this country and whose practices and spiritualities were, are, and shall always be tied to the land and the water. Today's webinar is the second in our 2024 Climate and Health Equity webinar series as part of the Climate and Health Equity Fellowship. The fellowship recognizes the need for more diversity in climate and health leadership, and really a sharper focus on equitable climate solutions. The goal of the fellowship is to empower doctors of color from populations that face greater burdens from climate effects and are underrepresented in medicine to become leaders in climate and health equity education, advocacy, and policy solutions. I'm Dr. Venice Curry, the Associate Director of the Climate, Health, and Equity Fellowship. Also joining me from the consortium to run the webinar is Program Manager, Program Assistant Clarissa Payton, and Clarissa will be available through the chat to answer any technical questions during the webinar. Our other team members are Dr. Shanita Johnson, Fellowship Director, Dr. Kimberly Williams, Program Manager, and Cesar Alberto, our Program Intern from George Mason University. The webinar series is hosted by the Medical Society Consortium on Climate and Health. The link is in the chat for those who are interested in learning more. It is held on the second Friday of each month at 3:00 p.m. Eastern Standard Time. Today's webinar will be recorded and made available to our YouTube channel and website for future viewing as part of the Equities Resources page on the consortium's website. This year, we are really excited to continue our initiative of offering CME credits for our webinars. Instructions were on the initial face page and will be available to show you how to obtain credit at the end of the webinar. As we near the summer months, and for some of us, we've already experienced some warm weather, really discussing the health and equity implications of extreme heat and sharing the resilience measures is more vital than ever. As healthcare providers, it is really important that you consider the healthcare system as well as the role that providers play in regards to providing information around climate and health and the impact that it has on underinvested communities and what those culturally specific solutions might be in emergency situations or disasters. Today, we are really honored to have some excellent speakers as always. We have Dr. Christopher Uejio, who is the Associate Professor, Director of Geography Graduate Programs at Florida State University. He is a researcher who works on the physical environment and its influence on human health and well-being. He's also the co-author of the CDC's Building Resilience Against Climate Effects framework, which is the BRACE framework. Rather than spend a lot more time talking about his impressive bio, we will place the link to it in the chat, and you will have access to reading further about his impressive work. Our second speaker will be Dr. Cheryl Holder, an esteemed clinician, educator, social justice advocate, community leader, and yes, chef alumni. She has dedicated her medical career to serving the underserved, and again, we will place her bio in the chat as well. The general format for today's webinar is two 20-minute presentations from our speakers, followed by 10 minutes of questions and answers from our audience. We ask that you put your comments or questions into the chat, as well as any links that you have that you think may be helpful or that you can recommend. We will get to as many questions as we can at the end of the presentations. We do ask that you please keep yourself muted so that we are not interrupted by any background noise. At this time, Dr. Christopher Uejio, we invite you to continue to begin speaking. Thank you.
Thank you, Dr. Curry, and many thanks to all of you for participating. I'm really looking forward to talking a little bit more about heat health and equity. Just do the cursory check in to make sure people can see the screen. Thank you. Wonderful. Great. Okay, so this is I'm going to unfortunately tell some bad heat puns inadvertently, but heat is a hot topic, and really we are sort of moving into that season. There's a wide range of experiences, and I'd love to hear more about your own personal as well as professional experiences in this area. But I'll just be talking about heat health and equity, as well as with Dr. Holder, who we have collaborated with in the past. Okay, so the BRACE is a 5-step framework, as Dr. Curry mentioned. It's actually being updated in a beneficial way. It's going to center health equity much more than it did in its initial iteration when we wrote it 13 years ago. So, but nonetheless, just to sort of help us be on the same page, I'm just going to walk through the 5 steps of the BRACE framework. Those 5 are still there. They're not being overwritten, but they're certainly being improved, and with sort of an eye towards heat. So extreme heat, one of the first things we do as working as a health department or working closely with municipal and other local leaders is really understanding the characteristics of the periods of time and the places where people are disproportionately suffering from extreme heat or any other climate-sensitive health outcomes more broadly. As you folks know, there's many well-established ways to do this. I'm just going to show a couple more that are a little bit more interesting. We know that there are established vulnerability or environmental justice screening tools, but those in themselves, can be improved particularly when we're just focusing on a specific exposure and health outcomes related to adverse heat. So in this case, this is where we're trying to develop the first updated maps of air conditioning prevalence or access to air conditioning. That may sound like, well, someone should have done that already. I completely agree. I wish someone else would have done it. It used to be collected up until the 1980 United States decennial census. So we essentially have this 40-year gap where we do not know the specific neighborhoods that still lack central air conditioning. Obviously, that's access to air conditioning in and of itself is insufficient. You also have to be able to use it and repair it. But this is sort of the first step, and this is some of the work we've just done in Florida. Both neighborhoods with higher portions Black African American, as well as those as historically red line neighborhoods, are more likely to have higher proportions of residential households without central air conditioning. The second step of the BRACE framework is projecting how climate change adversely impacts health. And this one I sort of purposely meant to be somewhat wonky and outside of the standard wheelhouse. So this is just to highlight that we need to work with atmospheric scientists and environmental scientists, whoever has a deeper understanding of the exposure. In this case, this is a schematic of some of the atmospheric conditions that produce heat waves. So we know that actually in a place like the southern United States and in a place like Florida, that it's actually the consistent, grinding, constant hot and humid conditions that actually lead to more excess mortality and adverse health outcomes. But that being said, in many places, particularly more in the western and higher latitudes locations, it's these relatively rare, every few years, but extreme heat events or heat waves that actually are killing at least a sizable or more attention-grabbing number of people. I won't walk through all this, but I'm happy. But essentially, if we wanted to understand how that changes in the future, we do have to collaborate and have an understanding, not just that things are going to get warmer or more humid when we plug them into a model, but why? Is that due to some atmospheric process? Just like we might be interested in the physiological processes in the medical community or in the public health community, the social and combined physical processes. Step 3 is really where the public health department's really enjoyed engaging with, and that's and I think for many of you, there's an emphasis on, okay, we know heat's a problem. You don't need to convince me. What can we do about it? And Dr. Holder and I both worked to varying extents with the world's first extreme heat chief officer, Jane Gilbert in Miami-Dade County. This is just a picture from one of their plans, but they went within 2 years of rapidly not having an extreme heat plan, engaging the community, developing an evidence-based plan, and are deploying that sort of at scale, with tens of millions of dollars of investments in green infrastructure, requiring all their public housing to have air conditioning, et cetera. We're happy to talk about that further, but I don't want to steal Dr. Holder's thunder. So this is building off Miami-Dade County. They have 3 sort of concrete goals: inform, prepare, and protect people, cool our homes and emergency facilities, and our neighborhoods. So we want to obviously implement equitable interventions, assess how to make sure that they're working, and improve them over time. Okay, so I'm going to go with a bit of a deeper dive into sort of the heat mechanisms today. I think some of you are already quite familiar, and there's literally hundreds of studies that have been published showing that outdoor conditions, when it's hotter and more humid, more people seek healthcare for a variety of conditions, whether that's an exacerbation of a pre-existing health condition or a sort of more of an acute heat onset case. Okay, normally I'm time limited. Normally I make this a little bit more interactive, but if you were to guess, all right, I would say something like, how many people die of extreme heat in the United States per year? According to the CDC, well, yeah, why not? Why, if you don't mind, feel free to throw some numbers into the chat. So this is sort of heat exacerbated deaths. So that's not necessarily listed as the primary or even the 10th cause of death on the coroner medical examiner's report or certificate, but if using our best methods, how many people die of extreme heat per year or excess deaths in the United States per year? Great. Thanks for putting in some numbers. Great. We have some in the tens to hundreds of thousands. Yeah, globally, probably more towards the hundreds of thousands. In the United States, our best estimates are about 10 to 12 to 15,000 excess deaths. So again, there's not going to be listed on those official certificates. And if you ask the CDC, unfortunately, they don't report this excess number. They report sort of the clinically classified, which we know is an undercount of about only 1 in about 100 of those gets counted. I'll sort of go through this relatively more quickly. We know that everyone is at risk from extreme heat. Some groups, though, are more at risk, right? And not just innately, right? Due to social conditions or environmental exposures. Older adults are more sensitive, have more likely to pre-existing health conditions, take a variety of medications for those pre-existing health conditions that increase heat sensitivity. Young children and pregnant people on certain periods of gestation are more sensitive. Young children, smaller body sizes, less ability to communicate might lead to them being more at risk. The low income and unsheltered or unhoused, essentially having not the means to cool themselves. And there's been studies in this area that we know lower income households turn on their air conditioning if they have it and are forced to tolerate higher and potentially dangerous heat exposures. Athletes and outdoor workers, people who have high occupational or recreational heat exposures. So a combination of different groups here, and they show up in different data sources in different ways. Okay, just to, I'm not a medical doctor, but I'll defer to Dr. Holder, but recognizing my audience, by and large, the depth of the literature in the field suggests that extreme heat has adverse impacts on the cardiovascular system, which you folks can speak to more, right? But both from a theoretical perspective of human physiology, as well as the epidemiological literature, as well as our laboratory studies where we purposely expose people to low doses of extreme heat who are healthy. Not we being the scientific community, not me particularly. The respiratory diseases, there is a fair amount of literature also suggesting extreme heat to exacerbations of respiratory diseases. It's somewhat confounded by air pollution. largely ozone, ambient ozone, but also more and more these days wildfire smoke. Obviously heat exhaustion and stroke. And then sort of an emerging literature, which is not quite settled, but on kidney function and, and kidney and renal systems functioning. Okay, so diving in a little bit more to the weeds, there's tons of studies connecting outdoor heat exposure to adverse health, but there's actually relatively few, like literally we can count them, 15, if that, studies connecting indoor heat to human health. So much so that the World Health Organization says, well, they did their own review and included a couple of our studies and said, well, yeah, there's some suggested evidence, but we can only give this sort of a conditional recommendation just because there hasn't been enough of these studies. So I'm just going to present the results from one of these that we did in Atlanta with Grady Emergency Medical Service and Dr. Yancey, who is also affiliated with Emory University, as well as others. So do higher indoor heat exposures alter the odds of heat-sensitive emergency distress calls versus others? So it's essentially a case control study design. Due to time, I'm unfortunately not going to go into all the details, but I'm really happy to send more references or things like that. But essentially, we have to have some sort of comparison group based on to get a sense of this exposure systematic related to exacerbating, in this case, respiratory or renal distress calls. So we have to come up with a case definition. This is where, to be fair, I think those who are our clinicians would be like, can you really come up with a great case definition just from emergency medical service or paramedics evaluations? And I think that's fair. That's not exactly, it's not going to have the same level of rigor as someone who walks into an emergency department. For sure, there have been some studies that have compared them and said they're not bad, 70 or 80% agreement. Anyway, so we had to come up with some sort of case, those of an exacerbation of diabetic conditions, so that we can get that from both the dispatcher when they call them, the on-scene evaluation, and the treatments that are administered to the patient. In the interest of time, I won't walk through the respiratory one, but that also shows an association. So we have to get some sort of comparison. So we have a comparison group. The main point being that it should be largely similar to this case group. So those people who make 911 calls. But we know that just from that previous slide that people, older adults and people who are sicker are more likely to still suffer from extreme heat. So we tried to come up with a case condition, and then we have to sort of statistically adjust after that fact for these groups are generally similar, but not exactly the same. So essentially, the emergency medical personnel carried in sensors, temperature humidity sensors, into the environments where people are receiving emergency medical care. We can link that to their standard patient care reports that they collect for insurance billing purposes. And then we can essentially come up with this sort of case control study design. This I have expressed in terms of log odds. I'll try to walk us through this a bit, but essentially number one, there's a relationship between indoor heat and the odds of making our diabetes related distress call versus our comparison group. But it's nonlinear, meaning that essentially there's not a huge association. It's sort of these modest indoor heat exposures, but particularly when we start to get to these higher indoor heat exposures, we start to see notably more increased risks. I know this log odds is a weird way to express things, but if you get towards the log odds of 2, you're getting much, much more likely to make a diabetes-related call versus a comparison call. So long story short, some evidence in this to support that, and particularly in Atlanta. Okay, so to try to contextualize this, there's a bit of a disparity, I think you will, based on the literature, but I wouldn't necessarily which is sort of easy to explain from a health equity perspective. So there are studies, as I mentioned, where they do expose people, volunteers, to heat, which my group doesn't do, but when they have exposed people with well-controlled diabetes to relatively modest levels of heat, they're able to tolerate it. So that actually suggests that if you have well-controlled diabetes, it actually doesn't necessarily increase your heat sensitivity. But given that this was Atlanta in the United States, where going to think that essentially these are going to be a lot of uncontrolled cases of diabetes then that are increasing heat sensitivity. And I know that's a lot that I'm throwing at you. I will try to, open to feedback. So then I'm just going to switch to the second one, and this is just, I'm going to pay less attention to this one, but just to give a, given the theme being on equity, some other work we've done looking at heat and social security numbers. So we essentially used a similar sort of study design, case crossover study design, but we were really interested to see for those patients who go to the emergency room in Florida, if you report a social security number or not, does that modify your risk of experiencing different types of heat-related illness exacerbations? So to translate a bit, yes, we were interested in citizenship status to some degree. This is obviously a notoriously difficult population to study for a variety of reasons. And the thinking being, if you had a very severe case of heat-related illness, you would seek medical care. So some of the biases in differential healthcare access would be minimized, but some of them are obviously still there. So case crossover study design, I'm happy to talk about it a little bit more later, but essentially you use an individual person as their own control. But this is just another way to get at building systematic evidence. So essentially, if we only know information about the cases when someone sought healthcare at an emergency department who reports to the state of Florida. So we can implicitly then determine if they didn't seek healthcare for a similar condition in a period a week before or a week after, then we can sort of tease out if that hotter period is more likely to produce a case or someone seeking healthcare for a heat-related category. So I tried not to show wonky tables, but I'm happy to show odds ratios and things like that at another time. The main take-home message was, at least based on severe heat-related illness, that it had to be severe enough to be seen in the emergency department room. Largely, these groups were similar. So people who did or did not report a social security number. That being said, there was a couple of outcomes where there was some evidence that those who did not report a social security number experienced higher odds ratios. So they're more essentially the entire population of people without a social security number was more sensitive to heat, all else being equal. For those that are reporting cardiovascular and dehydration related emergency department calls. So trying to talk a bit about where things have been and where things are going with a bit of a bias in my presentation towards some of the newer things, but I'm really happy to talk more about whatever you might be interested in. Obviously, this leads to things like water arrest and shade, which unfortunately the state of Florida, for example, recently passed a bill preventing local municipalities from passing legislation to mandate water arrest and shade for outdoor workers. Thank you very much for your time and your attention. I really appreciate it, and I look forward to your questions.
Thank you, Dr. Uejio. That was so informative and so comprehensive in sharing your information. We will hold questions till after our second speaker, and I understand that she has joined us, so we will transition to hearing from our next speaker, Dr. Cheryl Holder. And again, rather than take her time with the bio, it is in the chat. So we welcome Dr. Holder. Dr. Holder, you may begin. I'm looking for you. There you are.
Hi, good afternoon, everyone. I will be sharing screen. And sorry for, I don't know if I'm a little bit late or this is my time, but I was at another presentation and just got done. Let me do it here. And Dr. Uejio, well, hello, good seeing you again. Slideshow, and the start. All right, so I'm just doing a thing on climate change heat, and I'm sure some of this will be repetitive. I just usually start off just giving a background information that as chef fellows you should already have heard. So it's just a quick review. And then we'll go into more of what Miami-Dade County has been doing, which is pretty exciting. And I think Dr. Uejio may have discussed it before. I do have just conflict with Genentech and Medtronic last year. I did some talks for them. And again, the usual vulnerable populations, policies, and I'll go through those very quickly, just as a quick review, and then get to our HEAT program. And I always start off in honor of Anna Mae, who was the woman, that's not her, who kind of put the dots together and helped me connect the dots back in 2016 when it came down that everything I've learned about social determinants of health was presenting in Anna Mae, and that my diagnosis was totally inadequate. And what I was doing as a clinician was inadequate to really meet her needs by writing a prescription to refill her medication. But it was really, that was the tip of the iceberg. And underneath it all was our planet was warming. And as I learned more and you all understand the importance of hot nights, I was just talking to nephrologists about the importance of hot nights, because that's when you dehydrate and it gets very difficult to cool down if your nights are as hot as your daytime, because we really need the cooling. And we understand how human impact. And the reason I show this is that it's so important that we understand this and we do not deny it with our patients. And we don't defend the data either as we talk about climate change and pollution and what human has caused, but it just becomes, this is what it is. I often tell my patients, let's break it down. You got cholesterol, it circulates in your arteries, it builds up slowly over time. But let's say you have a natural amount because your body makes 85% of it. But that 15% that is added on, you decide to have a diet, and for so many reasons, your diet is so filled with stuff that it sends up that cholesterol even higher. And then you get that rupture of the plaque, and that's a heart attack. And for us, that's a hurricane. That's the extreme weather. And I work on doing the understanding that humans play a role, just like their diet and exercise and the environment and the built environment plays a role in how their health is. That's what it is. So we no longer defend the human impact, but we own it and we educate on it. And we know, we let them know why it is and how these particles are being blocked and it's warming our planet. And it's all about CO2. But what's so important is as the temperature increases, the heat, the small variations, and the trending towards the heat, and especially the nighttime. And this, again, is just more information that you know, and you can explain it, that the temperature is up on our planet, shouldn't be too hot, shouldn't be too cold, and we're missing that just right temperature. And we understand what's causing it. And here we get into the health sector. And again, if we do not address the health sector, we have some evidence that we're moving that way. We had more people sign on with the White House global letter. We had more push of Joint Commission creating a voluntary standard. And now the Hospital Corporation, by 2026, they're moving towards a standard. It's still voluntary, but we're getting to the point where everyone is beginning to understand the urgency of the situation. And you'll understand more about the health system contributions, and you'll get more of this information. But as a system where we are in Miami-Dade County, we are tackling change and we're tackling heat and we're tackling educating the population, but we haven't quite tackled the role of the health sector, but that's coming. And you've seen this before, where we understand fully about the direct impact, the spread of disease, disruption of food, well-being, and using that mnemonic to help guide your learning. With heat, this is the part that we try and get folks to understand that it is the #1 weather-related killer. And it happens so insidiously. And at temperatures where I am in Florida, where it's not the absolute temperature that you worry about, but it's really the index, the heat index, the humidity that is in the air, that so when your body sweats, are you able to adapt and cool it because the air is blowing on you? You'll see in desert, they can use a 95 degrees because it's dry. And so when the body sweats, you'll get the cooling. But not so where I am in many of the southern states, especially where most of the most vulnerable population lives, which is in the South. And so it's very important that we understand and our patients understand that when the humidity is high and the temperature is high, not even very high, but 80 degrees, and you're working outdoors and you're having prolonged exposure, you will develop the heat illnesses. And just 80 to 90 degrees, we start seeing the triggers. And that's why Florida did try, not Florida, but Miami-Dade County tried to put out some protection for the workers because we have almost 200,000 outdoor workers. We do a lot of construction, a lot of farm work. That means that, and also we are number one in the flowers. When you see those folks selling the roses on the street, they often come from nurseries, and many of those nurseries are indoors. Also, some of the manufacturing are indoors, and it means that it's hot. Some of those big warehouses, like the Amazon warehouse and those other warehouses, not all the time is it cool enough. So you have an increased exposure where we are, and they needed the rest to avoid the heat illness. By the time you're getting higher heat index, you see the progression. I know most of the chef fellows come from all over, but with South Florida, we do have the heat all the time. So even with acclimation, you will see acclimatization. You will see that they will still have exacerbation of underlying problems worsened by heat. In much of the Northeast and other places that do not have AC, not having acclimatization will make them much more susceptible in the early days of heat exposure to having heat waves and deaths, especially those older people who live on the higher floors. In Florida, in the older buildings, usually most buildings are 1 story, maybe 2 stories at most, but we're getting more of the newer construction, which are going higher. And as we see the temperatures rise, we anticipate more complications from heat illnesses. Our historical average was 25 days with temperatures above 100 feel-like temperatures. Just last year in 2023, I don't know if Chris told you the numbers was over 40 something. And we had in South Florida, we had 1 known death from the heat, but increase in the emergency room use, increase in calls, and increase in worsening of underlying health problems. We understand all the environmental factors that's related, and we've definitely seen heat leading to preterm labor and more low birth weight and those complications. We have started in our county, Dade County, linking the advertising in these communities with the worst rates of maternal outcomes, educating on heat in our communities because we understand what the role that heat plays. Same thing with asthma and allergies, again, they increase. Where we are, we have a large number of Hispanics and Blacks, and that's where we anticipate the higher numbers of complications from the heat, and especially the heat's impact with ozone, where it increases the ozone level. And with ozone going closer to the ground, we're seeing increase in triggering of asthma, increase in triggering of inflammatory responses to the ozone. We had malaria last year. It was a travel-borne malaria. However, it rapidly expanded in its area. And that was during the time of more water and more heat during 2023. So we saw the increase in the transmission of a travel malaria. And this is what we anticipate in our area, because with temperature rise, there is definitely more biting of the mosquitoes. And so there's increased likelihood of it spreading the disease. Even though mosquitoes die as the temperatures get hotter and their lifespan may be shorter, their ability to bite more and replicate the bacteria, falciparum, the bacteria in and spreading it increases. And we anticipate with the vectors rising in the location from South Florida going all the way up, we anticipate even more problems with heat. Again, chikungunya, dengue, there's a worldwide dengue problem. Brazil is probably anticipating about 5 million cases of dengue. Now, when you look at what happened this year with El Nino, which means the Pacific and the Atlantic Ocean being so warm, more moisture. So when it rained, it poured. So there was a lot more water sitting for the vector, the malaria, the Aedes aegypti to multiply, which then caused increased spread of the different diseases. This was Zika, but this year it's dengue. And so we expect more travel-related dengue, and we wait and see what happens during the summer if that continues as we have more water, more temperature for this, for the malaria, for the mosquito to grow. Again, with the flooding, our problem in South Florida is the flooding that the water comes from below, and it comes with the intense storms. We now have rain with so much accumulation in a matter of minutes and hours. So we're having the flooding both sides. When the water comes from below, because we're a limestone in South Florida, so the water comes up, it's displacing the table, the water table, which then displaces the septic tanks. So we're now seeing increasing nutrient-rich waters, and it also causes much more flooding. And then it causes our housing structure to get damp and grow mold. So again, the exacerbation of underlying infrastructure challenges for the low wealth population, meaning more health issues, and doing that during the heat. One of the particular areas that we get concerned about is the kidney, because the kidney manages the fluid. So with the heat-related problems, with heat stroke, you go all the way to rhabdomyolysis and acute kidney insufficiency. The recurrent heat and dehydration leads to chronic kidney disease, but then chronic kidney disease also worsens your likelihood of acute kidney injury, and it's just a vicious cycle. The increase in kidney stones in many areas, definitely in the South, which is kidney stone capital of the world, not of the world, but of the US. But there we're seeing an increase in kidney stones. Also the poor hydration, and remember nighttime temperatures causing more dehydration, that increases risk of recurrent infections, urinary tract infections. And I gotta add the heat. I have a patient, I'll tell you about him. He came to me with his hemorrhoids and feeling a little weak. He was a little anemic. It turns out he's an outdoor worker, and his hemorrhoids really started acting up last summer, and he got more constipation. The constipation just aggravated everything about his hemorrhoids, so he had more bleeding, and he finally came in. Now, this gentleman was trying to wait for his surgery because he's had this problem, but he was holding out to get to Medicare because he's uninsured and Florida did not expand Medicaid. So his hemorrhoid problem and the constipation now from the dehydration as an outdoor worker has led him to needing this service much more earlier and may put him into huge medical debt. But there's so many ways in which the heat will slowly exacerbate everything. And we have to really continue our efforts in addressing these needs. Climate and mental health, again with heat. The heat hazards, you guys know what happens with increase in change in mood, increase interpersonal violence, increased homicides, everything during the heat. You have the direct effects, indirect effects, all leading to worse outcomes. And the migration, we understand the social determinants. We know that the particulate pollution is worse, and heat exacerbates everything that you see here. The energy burden, which is what Ms. Anime came in not being able to pay her bills. But why did her bills go up? Because her housing was so poor. She lived in old housing. So much of the AC that she ran at night was escaping. So it didn't cool. Plus, when your outdoor temperature is pretty high, it takes a whole lot to cool your indoor temperature. So you do still need that cooling gradient outdoors to make a difference at night, to bring you to the temperature where you can be comfortable. So that really impacts the amount of energy use of the communities. The other thing that we deal with is the Latin population, that they're often in communities in the state, and the type of jobs they do, agriculture, manufacturing, construction, puts them at higher risk. So when we did all our efforts to mobilize the county to push for protection, this were the population that we were really trying to protect. And it's overwhelmingly male. So when we protect that male population, we're also protecting a lot of families. So we were hoping to try and prevent worsening poverty of a community that is already suffering. Again, with our ages, the elderly increasing. So with heat, the elderly do not have the ability to physiologically monitor their hydration status, recognize their thirst, and respond. Many times, even though they're hot, they'd rather stay in their hot apartment than leave, because of so many fears and mobility issues and cognition issues, that it means that they're increasingly very vulnerable to heat. And the other group are babies. And again, babies and athletes often are not able to monitor and adapt and respond well to the heat. And we've gone through our policies. This is the main thing that has happened from the policy, is that the economic breakdown. These cents have gone up. Blacks make a little bit more than 59 cents, but the ratio between what Blacks and whites make and Asians are still significant. But this is important in how much money will it take for you to adapt and be able to manage the heat. It's very difficult on our current income levels for the communities that we're dealing with to be able to get the resources to retrofit homes, decrease the loss of the cooling if they do have cooling, and even if they do have cooling, pay for the cooling and get the right amount of water, the jobs that will give them some protection, and to adapt to the nighttime. So we're looking at huge risk of the population, and we know it came from structural of devaluing communities based on their race. How much access to money and power do people have? And this is when we talk about social determinants. Policy drives your access to money and power. Redlining is important in that the redlined area will be your trigger to know which areas are very hot, because these areas did not get trees, they got mainly concrete. The housing infrastructure is poor, so their temperatures could be 7 degrees more than what we're seeing that's reported by the National Weather Service. That again means that this population is very high risk for all the complications from heat. This is Miami-Dade County, and you can see on the green side is where all the trees, it matches with the blue side, which all the money. And this is across the board, and we know it comes from hundreds of years of how people are valued their access to money and power. And we did, using that data, the Miami-Dade County, we have the heat vulnerability index, and that vulnerability index is a combination, just the overall temperature of the county and the projected temperatures in these heat islands, because they know the areas have been redlined, and the tree cover and the economic factors, and they all come together to create a heat vulnerability index. We have identified the biggest areas, and these are areas that are primarily Hispanic and Black communities. And it comes out of from the previous Jim Crow era of the areas that were redlined, the areas that were where Black folks were placed. And of course, those are the areas with the highest average hospitalization and ER visits based on heat. Now, we use that data. This is just a census. You know, I'll come back to this stuff. This shows about consumption of goods. This is very similar to what happens in Florida, in where my community. If you look at all these communities here that you're seeing, most of these communities, most folks don't have cars. Most folks aren't running AC and spending a ton of money on anything. they do not consume the resources that some of the wealthier communities do, yet they are suffering the most. And this is what we see worldwide. The inequity in consumption of goods and services adds to the racial and ethnic disparities in air pollution exposure, and put heat exposure. It's just across the board when it comes to climate change. And again, when we talk about sea level rise, on the left is what would happen if nothing is done. And right now, this is where we are. We understand how it's happening, what resources are needed, and which communities. You remember the communities that you saw, the red, which is mainly Black and brown, those would be totally gone if we do nothing. Right now, they're very vulnerable, and we're hoping we can make some changes there. A lot of the other areas will be gone too, but we know there are changes that they've been doing: adaptation, raising sidewalks, elevating communities, putting up barriers, putting up natural barriers to help address this, and that's coming. I use this and I encourage everyone to think about the problem, what we can do personally and what we're going to do as a society. This is coronavirus, but just think about everything that we can do as a society. And as clinicians, you can fill this in. You can see everything that clinicians can do. And for us, it does involve so much of research, education, doing these things with chef. But when you go back to your communities, because this is our third or fourth chef, I think, that we've worked on, third or fourth. And when you come back to the communities, your challenge will be, how do you take some of these ideas that's come up between what you're doing and what the community is doing and really make it impactful? Again, here, and I'm in the heat task force. And there we are educating. I just got a text from Clarissa. 2 minutes, thank you. This is the Heat Health Task Force, and that's a group. We've come together as a community. We have the first heat officer in the world. We've created an extreme heat action plan, and FCCA is the designated group to educate clinicians. And we've developed a way of creating a template where doctors can write a letter that meets the American Disability Act, so you can get personal or reasonable accommodation, education, employment, and housing if the weather is bad. Unfortunately, we don't have a lot of takers because, again, they're poor, they have no rights on the jobs, they're afraid of being fired, they're afraid of being evicted. But that is possible for us in Florida based on the way the Disability Act is interpreted in Florida. We're goal 1, inform, prepare, and protect the people. So we have a strategy where we give out CMEs, we go into communities, we develop the medical student practicum, we go on site in those same vulnerable areas and we teach. We have a lot of social media. I'm trying to get to 5,000 on TikTok. So if you have TikTok, just find Dr. Cheryl Holder and follow me and share and like, and so I can get to 5,000. And we do a lot of training everywhere. We've also started to integrate ourselves in grants. There was a big grant that came out of the U of Miami. And so we are partnering with 2 other organizations. We hope we'll win 2 of them, but 2 people who are applying for a program. They've incorporated us to train the workers who will be doing their diabetes education. So we will train them, and that's how we're getting funded. We're also partnering with another research group. As they go out and do their research, we're incorporating some climate education in the research. So that's where we're heading. Again, the maps that we showed you, and we're contacting all the hospitals and clinics in those areas based on the areas, and we're targeting the reds. And that's how we're educating the folks. These are some of our flyers that we're doing. We have our CHOT team where we train high school and college kids. And our medical student project, we have 77 students who oriented, 12 are completed. We've done op-eds. We just had our first article that was published in Curious, and I sent it over to Kimberly and she can share it with you, where we talked about vector-borne diseases and anesthesia. 3 medical students worked on it with one of our FCCA faculty person. These are just all the things that we're doing. And so we get back for you to remember anime as the main source. is that we're doing all of this to make our world better, but we've got to integrate it in everything. Because when a patient shows up, they're not just going to tell you, oh, the heat and it's climate change. They're going to present in a way that's very subtle, but we have got to connect the dots and make that change. Thank you.
Thank you, Dr. Holder, and thank you, Dr. Uejio. We have just a few minutes for some questions. These have been excellent presentations, and there's a lot of interest and a lot of follow-up questions. So if you do have a question, you can place it in the chat. We'll get to as many as we can in the time that we have. Are there any questions from the chat? I'll turn that over to Clarissa. No.
Yes, we had a question from Dr. Keel. It looks like Dr. Uejio kind of answered it a bit in the chat. Did you want to elaborate any more on that, Dr. Uejio?
Oh, I'm happy to talk further, but I think the chat's okay.
Okay, I do see a question in the chat.
Yes, let's see. It says, is there more you can say about the effects of heat on pregnancy and reproductive health, including the health of a developing fetus, if any?
The article is with Dr. Bekkar. Bekkar, I think he's out of California, Bekkar. He did like about 50,000, he went through 50,000 charts and saw the correlation. It's not quite causality, but he did show the trending of heat and pollution with the outcomes. And I can send the article over. He's also, if you go to our website, Florida Clinicians, we have his slide set, and the presentation should be up there also, where he summarizes the findings. But it's getting very clear about the heat, and many of these women in the urban heat islands are much more vulnerable. And when we tracked our data, where we see the women, where they're coming from, and what shows up in the hospital that's why we were able to get funding from the Women's Fund in our county to do the ads on benches, on the buses, and let the word out to the pregnant women.
Yes, thank you. And just one more, I think we have time for maybe one more quick question. The question is, you mentioned your area has the first heat index officer, a neighboring state. See, does Florida have a heat index officer?
Yeah, heat officer. The world has several heat officers. Sierra Leone, Greece, Florida, there's several. They were funded through a network of Adrian Arch Foundation and other groups. And it's particularly important that you have somebody lead the charge. And so with us in Dade County, which we are pretty much ground zero for heat, other than Texas, I think those are the two states that will suffer the most. And so having a heat officer is now put in our budget, in the Miami-Dade County budget. It was a grant funded position, now it's a budgeted position. So that's real important. We do have a Democratic mayor in our community. And honestly, that wouldn't have happened if it had been a Republican, because the Republican administration now has pretty much gone against most of the climate change initiatives. But the heat officer is who created the Extreme Heat Action Plan and leverages a lot of dollars for the county. And so they were the ones who leveraged the additional dollars for us through the foundations. And then we were able to get the dollars to do our work. So if you can get somebody in charge and push for a heat officer in your area, or whatever your major climate risk is, that would be very important.
So again, I want to thank both of our speakers for their excellent presentations and for the audience for joining us. I know this discussion can go on much longer, but we do need to wrap up the session. I hope that you found it useful and that you know that our webinars do meet every second Friday of the month. Our next webinar is May 10th, and we'll cover extreme weather events. Before you leave, we do ask that you take a moment to complete the survey. If you haven't already, the link is in the chat, and the information on how to obtain your CME credit is also listed. You can scan the QR code on the screen, and today's activity code for CME credit is 13143. This now concludes our session. We thank you again for joining us. We look forward to seeing you on May 10th.